to primary health care. But within those limitations, how best we can provide the health services. So this model, what I am saying is whether we can show that by adding these components into the public health system, whether we are saying ASHA, some of us are seriously saying there should be a second ASHA. Of course, Sujata Rao may not agree on that, but as a social activist.
There should be 5 ASHAs.
5, okay, good, good, very good. So additional, those components, we need to empower those community, the NRHM, the 5 important pillars, the communitization was the most important pillar. But unfortunately, it was not taken up till late in the implementation of the NRHM. So that was unfortunate, and that's the strength of the NGOs, the foundations like you and many of us. We are good at communitization process. Can we partner with the government and see that we have better results? So scaling up is to show that by adding a certain components within the existing system and improving the efficiency of the system, we can bring about changes. But technological packages like Gadchiroli experiment of just adding a home-based neonatal care, which is still, I am still for it. I don't know in this project why it was not thought of in tribal areas, because that antibiotic has saved many lives in Gadchiroli, which the health workers used to provide. So we need to think of those technological packages, but IMNCI is there, which was, I've seen the big debate between facility-based neonatal care and the community-based neonatal care, big fight at Delhi level. I don't think we will resolve it. I feel both are important. Home-based neonatal care is as important as the facility-based neonatal care. And we need to build up and show which are the efficient ways in which we can do it. Now coming back to, I was a chairman of the task force on health and family welfare for Karnataka government. We analyzed, took 2 years of work. There were a lot of NGOs and the bureaucrats also in that committee, and we finally gave the report, and we identified 12 major issues of concern. And on the top of the list was corruption in the health system was one of our serious major issues. Our health secretary was very upset. You're writing a report for the government and you're putting corruption on the list. How can I present it to the chief minister? Bring it down to 4th or 5th. These are the exact words he said. Don't put it on the top. I said, sir, if we don't, it was based on evidence. We took 2 years to build up these task force recommendations. I said, it's based on evidence. How can we not tell the truth to the government? Finally, it was accepted as it is. And several reforms have happened. Still, we wanted a public health cadre, which is yet to be implemented. There are many things needs to be implemented, but we had a very progressive Justice Venkatachala as the Lokayukta. He started visiting hospitals. So I gave him a copy of this report. He glanced through and called me next day. You identified corruption as a major issue. Why don't you help me? So I worked as vigilance director in Lokayukta for 4 years with ₹1 salary from the government. And I had a lot of insights into the whole bad management, corruption, bad governance, very, very important. I also have a very quickly, I want to say, we had a World Bank project. I was the chairman of the task force. I had come to know there was some corruption in. So I raised this when the World Bank team also came. But they listened to it and then went back to the health secretary and complained against me. The task force chairman is talking about corruption. So the secretary wrote a 2-page letter. How can you raise the corruption issue with the World Bank team? This was in 2007. So I said, this is a loan money and we have every right to see how the money is spent, and we need to take precautions to see that money doesn't leak. But now things have changed. In the present World Bank project, they are also monitoring the indicators for governance and management issues also there. It's a long way, though. Even World Bank was allergic to the word, the corruption. Now, having said that, the corruption is a major issue. The leakages are tremendous. Procurements, drug procurement, equipment procurement, transfers, and at least now in Karnataka, I want to document this. This is where the research is needed. And my thesis is mere technological packages of VHWs or HPNC, all of them will give marginal outcomes like what we have seen today. But if we have good governance, we will have quantum jump in health outcomes. This is my thesis. I want to prove it. In Karnataka, we have this opportunity to study that. I've also seen about 7-8 bureaucrats changing in Karnataka. I've also seen the health ministers. We had one Sriram Lu is a mining giant. Ethically is not the right person, but he was the most honest. He never bothered to take money from drugs and equipment. He had his own helicopter. So make a rich person as a health minister Or next, the portfolio went to the chief minister. He was too busy with other things, never bothered, allow the bureaucrat to do it. And the third one, we also had recently, fortunately, we were lucky to have one of the very good bureaucrats, honest integrity. I know him since he is assistant commissioner. And he was identified with BJP when the government changed, the Congress government came, and that to the minister was a Muslim. So we thought there will be, but it all worked out that he was also convinced, so he's continuing. So we have 3 years of good governance. We have a transparency policy and act. The major money making is, as I said, drugs, equipment, procurements, and the transfers. We have a transfer policy and an act. Now they are all done by counseling. No, very little interference in the transfer policy. Things are working out very well. So I want to see that we can, if we have very good, research team like that, we can show very good results that good governance can give quantum jump in health outcomes. Why I'm saying is as a private sector, we should not only become contractors of the government in implementing certain programs, we should also contribute as citizens, as a civil society in public policy, in planning, in implementation, in monitoring, supervision, research, everything. So our role is very important, and I would call this a good process of public-private partnership. And I am emphasizing this in Andhra Pradesh. Some of Andhra Pradesh Health Department still does not accept public-private partnership as a good process with the civil society. I am not advocating for the private sector, but let me also make it clear, private sector is very important. For that, we have a good instrument like Rajiv Arogyasri. Purchase the services for the poor. Don't make them pay, the poor should not pay. So in Karnataka, we have similarly Vajpayee Arogyasri, we have Yashaswini, we have RSBY. All of these are mechanisms by which poor are protected, and the services are bought from the private sector. That's fine. I have no problem. That's not privatization, because public health system is not geared up to, ideally public health system should provide all the services. When they can't, they should purchase services for the poor and pay for it. So hopefully we will have better partnership, public-private partnership, especially foundations like where we are seeing excellent work, commitment, communitization process is our strength. I think there should be more partnerships. Thank you.
Thank you, Dr. Sudarshan, especially for number one, emphasizing the important role of good governance in the public health system management, and also the need for more win-win partnership with not-for-profit civil society type of an entities and the government. Now, I just lastly, I would like to request Ajay to give his comments, and before I do this, I just want to share a few data. I mean, the Kerala, Tamil Nadu and Maharashtra, which is sort of comparable, Kerala, though it is really far ahead always, they've already achieved the MDGs. And West Bengal, I mean, which really was nowhere in the situation, which no one considered really as a serious contender of a good performer, is likely also to achieve both 4 and 5 MDGs. If at least it's so, what is holding back Andhra Pradesh?
It's very good afternoon to all of you, and I think I'm enjoying the idea that the Principal Finance Secretary has asked me what is holding back Andhra Pradesh.
You, one word, you.
I'm really delighted at that opportunity. So, but that I will also respond to separately in private. But first of all, the champion trial, I think it's wonderful that we have gone through these 3 years of trial, a lot of preparatory work before that, and then 2 years of fairly rigorous analysis, and with following very rigorous research methodologies, arrived at certain figures. If we have, as we do have, infant mortality rate, it has come down now in 2011 results which we have now, which have come out now, those indicate that it is 41 per thousand. If infant mortality today is 41 per thousand, then there are definitely pockets which are having a much higher rate, because in many of the urban well-provided areas, the rates are definitely much lower. We know from our statistics that in many districts the rates are much lower today, especially some of the districts which are adjacent to Tamil Nadu. But the tribal areas are definitely the areas where we have a more serious problem. A problem because of the remoteness, because of the non-availability of road infrastructure, because of the non-availability of many types of government infrastructure, because of also the reluctance of professionals to actually professionals all gravitate towards the urban centers. So while we have a large presence of doctors, large availability of doctors now in the state, the availability of doctors is still not good enough in the rural areas, and it's very bad in the tribal areas. So all of these, I think, contribute to the kind of situation that this trial has thrown up so vividly. It's 69 per thousand in the control areas, and then even with this kind of a very concerted effort and with very committed professionals, guided by London School, and then very good professionals here, and then at the district level and at the grassroots level, with close monitoring, could actually bring it down to 52. On one side, it is very commendable, but that 52 also is extremely troublesome. That such a concerted effort also sort of stopped short of taking it further is also a very significant reading. I think it brings out the results also bring out the success of deeper community involvement, of improving the awareness, heightened awareness among the pregnant women, among others around them, the village sarpanch, the entire village community. The role of being available to connect them to the service providers at the right time, identifying those service providers and making sure that some very basic services are available, and that the women, when in active labor, are quickly transported to the nearest service location. Good supportive supervision, the monitoring on a daily basis of what is happening, what is not happening sufficiently, the support that is given by the entire team. I think these are the major successes. These are the key lessons that we are carrying from this experiment. In Andhra Pradesh last year, in September last year, there's one significant initiative that we embarked upon called MARPU. MARPU means change. MARPU is actually an effort, it's basically recognizing that we have some difficulty currently in meeting the MDG goals. It's an effort to accelerate our attack on IMR, MMR and malnutrition. And the methodology for that actually incorporates many of the things which have been tried out in the champion trial. First of all, getting all the important departments to work closely together. I think the government was kind, and maybe deliberately they posted me in health and my wife in women's development and child welfare as the principal secretary. And that also helped us to sort of bring together a program which tries to combine the strengths of these. Of course, the state has gone through certain, disturbed conditions on account of, the threatened division of the state and whatnot. But for various reasons, the MARPU program has seen its ups and downs. But number one, MARPU program attempts to bring all the departments together. It attempts to combine a converged action from the department side with deeper community involvement, deeper involvement of the self-help groups which Ma'am Sujata Rao has just talked about. Trying to get these three entities together, health, nutrition, which is ICDS, and the self-help groups to meet and decide for themselves the key issues in health and nutrition and how to tackle them. And trying to also stimulate effort, stimulate demand, as well as get community involved in some of the social issues that contribute to this. We have a very low age at marriage. We have pregnancies, a large percentage of teenage pregnancies, especially in these areas which we have been tackling. So some of these are better tackled through community action than through governmental action. So MARPU program is one response that we are focused on. The NRHM has, the National Rural Health Mission has brought in very significant funding, very good, well-developed interventions. Many of those are, some of them are in place, some of them are sort of halfway through. We today have the special newborn care units in, we have 44 of these units, 38 of them are functioning reasonably well today in Andhra Pradesh, some of them are functioning extremely well. These have the ability to take care of premature births, children born with very low birth weight, children born and sick right at birth. Children get shifted even from the private facilities into SNCUs today. So we have improved our ability to save such children. We have similar smaller units called the newborn stabilization units in the area hospitals, and in many of the area hospitals, about 156 of these. Some large augmentation of MCH blocks is on the way, initiated when Dr. Ramesh was the principal secretary. But MCH, the mother and child healthcare blocks, adding about 150 bedded facilities to each of the district hospitals, at the district level. Many of these are only, at an advanced stage of construction. They are not yet fully operational. But all these go to sort of add to our supply side